all our meetings, members, and my dear colleagues. Today's CME is it highlights. Today we are deeply honored to have with us Dr. Professor Vinay Duddalwar. He is the Vice Chair of Radiology at Los Angeles General Medical Center and Professor at USC USA. Sir's vast experience and pioneering work in advanced imaging and AI applications will undoubtedly help us to gain global insights and further inputs in this field of nephrology. So I welcome you, sir, wholeheartedly. And now I hand over the further proceedings to our Honorary Secretary, Mr. Dr. Amol.
Thank you, sir. On behalf of the Nephrology Society, I welcome you all. And for today's program CME, we have a topic of ADPKD through the radiology lens, from renal structure and function to the artificial intelligence. So for this, we have a chairperson. I please Dr. Shivnarayan Acharya sir, Dr. Ashwin Kumar Khandekar sir, and Dr. Amit Pasai sir. So I request you to please take a chair, sir. Okay. Now, sir, I invite Professor Vinay A sir for the talk, sir. Sir, stage is yours, please.
I welcome you here. His biodata is of only 48 pages. So I'm going to read each and every page. So in next 48 minutes, I'll be talking, and then you may possibly talk for about 10 minutes or so. No, I won't bore you, but I'm very glad that he belongs to my alma mater, Government Medical College, Nagpur. And he passed out, when did you pass out? 89. 89. So almost after 4 years when I left GMC, after doing my MD medicine, and I was in Duddalwar hospital at that time. So I welcome you on behalf of Nephrology Society. Our society, it holds clinical activity almost once a week. And we have got 3 medical colleges where we have got many PG students. And in this audience, you will find half of them are PG students. So you'll definitely, we all will be benefited by your experience, by your knowledge, and I'm really very glad to welcome you here. Thank you.
Radiologists up here, but I'll show you some of the reasons why I believe that there's the facet of medicine called convergent science, in fact of any science, that the biggest problems in science, especially in medicine, are best solved by multiple people acting together, rather than one branch or one section of medicine having all the answers, which are never going to be feasible. It's always coming at a problem from different sides. And that's how I practice, that's how I do my research, and that's how I try to train my trainees as well. Vasu has been my classmate and friend for a very long time, and he knows that I'm always thinking of things in a different fashion, a different manner, and that explains my career trajectory as well so far. And some of the things you might see are like, I've only got 1 or 2 images from radiology, and mainly trying to put forward this sort of view and sort of strategy. A couple of years we started tackling autosomal dominant polycystic kidney disease, and that's what I thought might be of interest to you, and hopefully I learned something from this. Next please. Do we have a we're going to talk about? Next slide please. So this is my lab. I set it up about 10 years back, and each of the sort of graphic things represent some of the things that I hold true. It's multidisciplinary, it's full of students. I have students from engineering schools, science schools, all the way from high school all the way to PhD students as well. And that keeps me active and excited. They also throw a lot of questions at me. And my main issue I focus on is translational science and translational medicine. There are amazing discoveries in basic sciences, biochemistry, pharmacology, pathology, but none of them, or very few of them, actually make it across to clinical practice. And the reason for that is various reasons, including the time that it takes from something from basic science to make it across to clinical medicine has such a long process. It takes years and years before it can be implemented. So what I try to do is use imaging, radiology, to sort of bridge that gap. And translational science traditionally has two what's called valleys of death. The first is because there's so many of the basic science research and discovery is on things which are not really applicable to clinical medicine. So by doing this, the way we are trying to do it is bridging the gap between what is needed clinically and trying to find what is available in basic sciences and bridging the gap with that. Next slide, please. You know everything here, but I put it on there to just remind myself. It is the commonest inherited disease, not only in the kidney, but the commonest inherited disease which has a significant healthcare cost. And one of the things that is important to remember is the cost of dialysis in the US is so high that it outstrips the cost of many of the cancer treatments as well. And because it's chronic, that is an issue. You know the cause of it. It affects between 1 in 700 to 750 in the US. Similarly in India, slightly more, but it's obviously underdiagnosed in India, simply because of the dearth of access and perhaps the most remote portions. And at least in the US, 5% of chronic kidney disease have polycystic kidney disease, and that's the cause of the diagnosis. In India, I mean, this is obviously you have far more experience in this, but the age of diagnosis is higher. Symptomatology is also different and higher as well. The main issue is this: by age 60, half of the patients will have gone to some stage of end-stage renal disease. Next slide, please. You know all of this again, but what I'm trying to get to you is what we are trying to do is sort of bridge the gap, making the diagnosis earlier, but also trying to find triaging treatment strategies, trying to triage what can be done better, faster, earlier, at the least possible stress to the patient. Obviously, what is known is the cysts keep on increasing in size and number, then the individual cysts can get complications as well. But at the same time, there are other changes happening in the vasculature. You have filtration issues, the functional issues that happen, and obviously the kidney function starts decreasing, but it's a combination of both the cysts as well as the functional element as well. Next slide, please. To me, everything boils down to, okay, why does a disease cause symptoms and what is happening? And that lets me understand how it can help these patients and you all as to what we can do. So two issues. One is mechanical, essentially functional nephron loss, and the second is functional. Can we sort of give you some idea on how you can treat the patient better by triaging patients as to who might benefit best? Obviously, it's the disease is caused by two mutations, polycystic kidney 1 and 2, polycystin gene mutations. There's only one treatment that's FDA approved. There are a couple of others, including antihypertensive treatment, S inhibitors, and so on and so forth. But tolvaptan is the only drug that is currently used. And what I'm going to talk about is something that we've started doing. It's the first national trial which has just started on using bempedoic acid. And my lab is a central radiology lab for all the centers of excellence in the US for this specific trial. And so I'll sort of lay out what we're trying to do and help and try and predict what the treatment response will be. Next slide, please. Simple things. We all know what happens. I'm showing predominantly MR because that is what is commonly done to map and stage the disease. Very simple sequences, essentially without contrast, just layer it out. We get an idea of the volume, the size of the kidneys, and the number of cysts and the volumes as well. If we see something complex, we can handle that differently. The reason why they're being laid out in green and blue is the two areas that we're looking at. One is the green as the functioning nephric tissue. That gives an idea of how much renal function can be is preserved at that time, but eventually will start reducing. And the blue is obviously non-functioning cyst-like structures. And both of these impact. And remember that there's one biomarker which has been approved, at least in the US, which is the height-adjusted total kidney volume. That's the only single biomarker, just like you have a blood sugar or PSA level, you have height-adjusted total kidney volume, which is accepted as not only a place where you can start treatment, but how you can triage patients as well. Next slide, please. So the total kidney volume has been used as a surrogate marker for end-stage renal disease, especially in polycystic kidney disease. And in Europe, it is actually used as a prognostic biomarker. It's not only used as a diagnostic, but also a prognostic biomarker. And as I mentioned before, one of the things is it's imaging. Whatever you do, whether you do an ultrasound, CT, or an MR, it's going to show exactly the same thing. Amount of tissue, number of cysts, and how much of the kidney tissue has been replaced by cysts. Next slide, please. So about 10 years back, there's a group of radiologists who made this consortium called CRISP. The advantage is not all of us get to see a lot of polycystic kidney disease. So this consortium got together a lot of studies, and we use that to benchmark whatever we do. Out of this came what's called the Mayo classification, and we'll come to that in a minute. Essentially, you classify based on the renal function, the age of diagnosis, and the height-adjusted total kidney volume, patients into 5 groups. And all of this can be predicted to loss of renal function over the next few years, and therefore, who's at most risk for renal failure and eventual dialysis. So essentially, treatment can be strategized depending on this. And this has effectively stood the test of time over the last couple of decades. Next slide, please. So how do we risk stratify these patients for therapeutic intervention? Next, please. One is the height-adjusted total kidney volume. This is as simple as we can. So this is why I like things like this. You don't need to be incredibly complex. A single measurement which is resistant to sort of inter-observer variability, everyone's going to get exactly the same thing. You have the patient's age and you have the total kidney volume. That's it. Next, please. There's obviously genotypic analysis, PKD1 versus PKD2, because PKD2 has a different disease profile. There's mutations, the truncating and missense mutations that happen. That is who's going to get what and so on and so forth. But we want to get into the details of that. Next, please. And third is disease biomarkers. Can we use what is existing in the patient's clinical chart rather than trying to create a new complex mechanism? So try to keep everything simple. Next slide, please. So the Mayo imaging classification is based on essentially 2 things. One is the height-adjusted total kidney volume, the patient's age on the x-axis, and essentially you distribute patients into 5 classes. We have an estimated predictive decline in renal function per year in terms of GFR, and we know that the class E and class D have the highest degrees of failure rate, and so you can start treating them more aggressively. Well, it's a combination of ACE inhibitors, plus tolvaptan, or plus something else, including antibiotic medications and so on and so forth. All of which we will try and delay the onset of dialysis. Next slide, please. So what has been done so far? Why do we need new trials? So landmark trials in this, we'll forget the molecular analysis side of things. everolimus, which is now used less and less for APKD, but mainly used for things like angiomachomas and stuff like that, which is an mTOR inhibitor that was used back 15 years back. But then since then, tolvaptan has sort of been the mainstay of most treatments. They started using it in sort of grade 3 CKDs, and gradually we're finding places where which patients benefit the most. Subsequently, we had the HALT A and the HALT B study to look at what we can do with standardized controlled blood pressure medication. Do you use ACE inhibitors plus something? Do you use something else? Do you use it in combination? Do you use it serially? And so on and so forth. Then you have the REPRISE study, which looked at tolvaptan versus placebo. Is it actually doing any good? Or is it a fact that due to statistical analysis that we see the effect of tolvaptan? Next slide, please. Rather, the improvement of the function, the loss of predicted GFR loss is about 2 to 3 ml per minute per year. That's still significant because it's not so much important in the patients with early disease, but more important in the patients that do longer and delayed dialysis, obviously better outcomes. But the one problem is there are significant adverse effects. 11 to 15% of patients have hepatic toxicity such that many patients have to stop treatment. There are other numerous reactions such that it becomes a huge issue. And as a result, it's still obviously carefully controlled, monitored, and so on and so forth. So there's been a lot of studies on, does it actually help that much? Is the small incremental increase in the GFR, the delay in onset of end-stage renal disease, so important that you're willing to accept that number of adverse events? And when you take it with controlled placebo trials with best possible blood pressure measurements, there is a slight improvement. But do you think, hey, is this really that much of a difference? It is still significantly different. Next slide, please. So subsequently, post-trial analysis of previous trials showed that even the small increase is actually statistically significant. And so there is an improvement in the disease prognosis. But what is still not clear is the effect of the side effects, which are pretty significant. Next slide, please. So we come to what's called bempedoic acid, which is a drug that we're treating this now. Bempedoic acid is used for hypercholesterolemia. Currently, that's what it's being used for. But when my nephrology colleague, Ken Hathers, he looked into his lab in mice, he saw a significant amount of beneficial effect in APKD model mice. So this is not just random mice, but rather mice with the APKD model within it. And so it did have structural effects. It actually increased, rather improved the renal function. It reduced the onset of severe degradation of renal function as well. And so this has been done for the last 4 or 5 years, and now this is now translated to human trials. Next slide, please. So it's being used, as I said, for treatment of hypercholesterolemia, not usually as a primary treatment, but an additional drug. Next slide, please. It acts by 2 methods. One is it inhibits fatty acid and sterol analysis by the ATP citrate lysase cycle, as well as second is activation of the AMPK cycle. So the importance of this is because this acts differently from tolvaptan. And because it acts differently, essentially you can do it together as well. Next slide, please. The other good thing is directed to the liver and kidney, which are the 2 major organs. It's not directed to muscle, which other such treatments are bad, because if you look at any anti-cholesterol agents, most of them affect muscle, and it does cause a lot of problems as well. Next, please. So by using this drug either separately or in combination, that's what we're attempting to do. And so this new trial that has been started, and the first patient will literally just go on in this month. It's going to continue for the next 4 years across 4 centers of excellence in the US. It's a double-blinded study, so not only the patients don't know who's getting what, but even the physicians don't know who's getting what. So it's probably the gold standard of any trials that you can determine for this. Next slide, please. Next, please. Okay, keep skipping through this. Sure. So on mice, when we gave this, next slide, please. We found that not only the urinary biomarkers, especially KIM1 as well as NGL, actually reduced as well. So that not only functionally showed that the renal function was not impaired, but even the urinary biomarkers that were done. These are not done in real life, but only in the lab. Next slide, please. So here's what we did. Can we use it in the clinical cases? And this is what my interest is, essentially translating what we can learn from available tools. So using imaging as a surrogate for all these answers that we can try and give. Next, please. Next. So one big thing is combining bempedoic acid with tolvaptan actually hopefully can improve this. And bempedoic acid is actually an oral tablet. It's not even anything that is not injectable, and in general it is very well tolerated. It has a couple of additional benefits. It actually improves your cholesterol profile, and secondly, it also reduces the hepatic steatosis portion as well. So we're measuring that. Next slide, please. Next. So what we've done is this ADPKD trial, essentially bempedoic acid, and we're trying to treat polycystic kidney disease. It's FDA approved for another indication, but we're using this either with or without tolvaptan. This is being funded by DoD by over $9 million now. Next slide, please. Let's skip this. Next slide, please. Next. Okay, so this is what we are planning to do. Essentially, each patient goes in for 2 years. We only need, because the way it's being designed, we only need 120 patients. 60 patients in the placebo group, 60 patients in the patients who actually get this drug. We get 3 MRI scans, one at the baseline, one at 12 months, and one at 24 months. And we get a series of labs, the standard labs, and we're trying to reduce the amount of interventions that are done at each point. You have placebo with standard of care, so there's no difference in what the patient might be getting if the patient's getting an ACE inhibitor. Whatever it is, we don't change that. On the other side, bempedoic acid. Some patients on both sides may be getting tolvaptan, but that's okay. We can address that as well. Next, please. Next, please. And we're measuring all the urinary biomarkers because this is essentially this is a landmark trial. So we're trying to get all the information, trying to understand things that can be benefited, things we can identify potential problems, and so on and so forth. Next slide, please. So essentially, then we come down to this is the overview of the study. So how does radiology figure into this? Essentially, when we look at this, to me, this is a perfect situation where change the use of how you all, and we as well, will use radiology, trying to get more and more information to what is most useful, mainly to the patients, but also for you all. So the more questions you ask, the more we'll try and sort of address that as we go. So one, because this is not something that radiologists will do in normal practice. Manual classification, none of us will be aware, like I'm not going to be aware of what happens in the brain and so on and so forth. So a general radiologist is not generally going to be aware of all these things. So can we make it less tedious, less subjective, and try and automate this process? So simple things like the bottom question is, do we need to actually differentiate? Because we know that the disease affects the liver and the kidney. Kidney first, liver sort of secondary as a matter of magnitude. Can we use the abdominal sort of whole system together, and can we use the same process? Next slide, please. And the issue here is organ mass provides the anatomical context. We know that functionally the liver is completely different. Sorry for this, but completely different from the kidney. So why do we measure? Why do we need to measure the liver completely separate from the kidney? If we look at it from this process of what I'm trying to do is, this involves additional steps. Mark up the kidney, make sure it's accurate, and so on and so forth. So can we automate this? Do we need to automate this? And if we don't automate it, can we just look at the whole organ together? It is also unclear whether a single model that we can develop will segment everything out together. When I say segment, mark out what the lesion of interest is, give us a volume and an estimation. So we tested because we have access to the ADPKD study, 478 patients, plus this database on patients. So we're going through every single thing. My radiology residents working with me and students, they all segmented out. I go back and check and double check and triple check and so on and so forth. And that's why when we satisfy our internal process that, okay, this is as good as segmentation, we don't want anyone to keep on doing this, and then move on to sort of develop automated processes for this. Next slide, please. So this is where our pipeline for this part is. So we used almost 700 patients at multiple time points. Each of them has 3 to 4 time points, sometimes even more, plus the additional 120 patients in this trial. Not only are we looking at images, because I try to use every possible bit of information. Patients' height, weight, demographics, cigarette smoking, every possible thing, I put it all in. And the reason for that, based on, I'm not going to show it now, but happy to discuss with anyone who wants to, looking at other things in the kidney, the bladder, and other tumors. Second step is manual cyst segmentation. Each and every cyst we manually mark out digitally. And the reason for that is we're trying to automate this process. Then we use various model architectures. I never use anything which is sort of some model that say Google or Microsoft or Meta's developed. I never use that. We use that as a benchmark to test out what we do ourselves. And only that, because you can't use one single general purpose algorithm to identify this is a Santra, this is a Kela, this is a Apple. Nothing is going to work. I mean, they answer that question, but no, you can't use the same general purpose model. That's my firm theory. And therefore, we use different things that we've developed on our own, test it out and see, does it actually add value? Or can we just use something which is available in public domain? And so we check all that and we go back and see whether it actually makes a difference. And so one of the questions we try to answer is whether if we identify the right kidney separately, left kidney separately, identify the cysts in the right kidney, the left kidney, the liver separately, does make a difference. Next slide, please. So if you look at all these models that are coming up, the NN unit is one of the most commonly used models. And if you think of it as a student who's trying to absorb knowledge, the good thing is if it's a good student, it's going to not only do what you ask it to do, but it's also going to learn and try to do the process. So this is exactly what we saw. When we used it on about 100 patients, we saw that it was actually learning more and more, and eventually it's got to a stage where we don't actually need to tell it, this is the liver, this is the liver cyst, then do it separately for the right kidney, do it separately for that. We put it all together at the same time, we can get every answer, and with a very, very high sort of correlation and very little variation from what we could do in real life. Next slide, please. So these are just examples. How it is on the left is sort of completely, we're actually getting to a stage where you don't need to do anything, and within a matter of seconds, you're getting a very high accuracy. Is it still perfect? No, it's not, but we don't really need to be perfect to a level of 2 or 3 millimeters. So this is one of the things we try to address, right? Is it worth spending that much money, time, and effect in trying to improve the accuracy, say from 0.8 to 0.82, if it doesn't make any difference to you all? It doesn't make a difference. Next slide, please. So then I think we've addressed that, and we're constantly improving, trying to sort of make it more and more intuitive, more and more, and we're not going to let it go like that. We're not going to make it completely automated. We're still going to have a manual check, and I'll show you how we do it. The next stage is what we're trying to do in terms of building predictive models. One is there's a theory called conditional flow matching for disease progression. And if you look at, apologies for this going into this, but I needed time to understand this. I work with a lot of my friends and colleagues in engineering school, and this is what I've learned from them. I still work with them every week. We have state variables and you have conditioning variables. So in this specific disease process, you have the state variables with the kidney volume, cyst liver volume, and so on and so forth, and kidney function as well. But you have conditioning variables which we know at one specific time point. So we have, in this case, ACE inhibitors, type 1, type 2, it might be a specific type, it might be one type of diuretic in a combination, and so on and so forth. What we're trying to do is, if we know the baseline, can we try and predict what's going to happen 1 year from now, 2 years from now, and so on and so forth. So then you'll think, hey, this is kind of like buying a lottery, it's just tossing a coin and seeing what happens. But I'll show you examples of what we can do now. Next slide, please. So what we did was using 200 of those patients, which we have before, like I have almost 600, 700 patients now, using those as training sets and keeping on improving the model. Next slide, please. Apologies for the number of images here, but essentially the red dots are the ground truth. The black cross is what we predicted the function to be. So if you can look at the red dots, that is what the patient actually had. And each of these is one specific. One is the kidney volume, one is the liver volume, liver cyst, and kidney function as well. And if you look at the black cross, which is buried inside here, in some cases we don't match up, but in many cases we are able to predict. So just knowing what the patient's baseline was, knowing the age, the sex, and what treatment he or she is on, we're now able to start attempting. We're not going to be guaranteeing it, what's going to happen 1 and 2 years from now. But what happens with the patient you change treatment, right? So you remove one diuretic, put in the second one, and give them the second diuretic. So we're building those models. So that redundancy is not building it. So why are we doing all this? One, we try and want to give treatment to only those patients who actually will benefit from it. And two, if we know that a specific patient is going to sort of really good, not all patients are going to have the same linear response. You would think that every single patient has to have this sort of reduction in the decrease in renal function. It's not going to happen. If we have these tools available, it would be remiss on us to not try and predict what patients will go through. And this is what we're trying to do. This is at zero cost, right? Because we're not testing our own patients, we're not testing our own animals. All we're using is things which are available. Most of the things we can do are essentially on either home desktop computers. Next slide, please. Next slide, please. And again, we're talking about the same things, the things that we do. So this is what our goal is. What is clinically applicable? You know that there's a constant divergence in radiology and whatever you all do, and you have gynecologists and urologists, apart from all the nephrologists. So I've always felt that we report things in radiology, but don't really address the question that you all are interested in. And it's slightly different here, but in the US, 90 to 94% of all renal tumors that are presenting for treatment to urologists are without symptoms. We know that none of them have any biomarkers. Essentially, you are treating an asymptomatic patient with an imaging appearance. Two things happen. 22% of all renal tumors taken out in the US today are benign, simply because we don't do a good job. We don't have a good way of determining which is a malignant tumor versus benign. Out of the remaining 78% of patients, 34% of those patients have very indolent tumor. The patient is going to die of something else rather than the tumor. So 44 to 45% of all patients with a renal tumor who resect in the US today effectively should not have that. In India, most patients tend to present slightly late. So what can we do? So this is how we're changing the way we are doing things. Next slide, please. So looking at the radiology set, rather than just describe the size and image, next please. So we're looking at all of these things, and this is what I've done for the last decade. What is the immune profile of this? Just based on the standard of care clinical, we're not doing anything more. We're using 10-year-old scanners, nothing fancy. The scanners in GMC have met much better than what I use. what is the angiogenic profile, what is the expression, what is the likelihood of this patient responding to anti-VEGF therapy, what is the tumor mutation burden, what is the amount of necrosis, all of these impacts the patient's sort of malignant profile. If the patient has like more and more immunotherapies being tried, is the patient's tumor going to be immune cold, immune hot, effectively can immunotherapy work? Next slide, please. And so all these clinical questions that I've been hearing from tumor boards that I do every week, is there a cytoreductive strategy here and so forth. For every single bit of this, we now got tools. Some of it works effectively, some of it is very good. We've got multiple patents as well on the process, so we've got now 4 applied for the 5th patent now. So it works. The most important thing is it's based on a single clinical standard of care CT. Nothing extra, no other thing is needed. And we've now applied it across 2,000 plus patients at Cleveland Clinic as well, and the results are stood up. So it's not that this is just something that we've done on our own days. Next slide, please. Here's something else that I'm very much interested in. Healthcare in general leads to 4.6% of all global sort of greenhouse gas emissions. That is how much all of healthcare costs. You know this. Amount of heating, amount of chemicals, and so on. Radiology is one of the biggest culprits. 1% of all greenhouse gas emissions are simply because of radiology in its various shapes and forms. And along every single thing. And AI, the amount of energy being used by AI is now 30% of energy in 3 years' time. So for every single process that we do, we measure how much energy is being lost, how much water is being used to sort of cool down the computing. We're looking at everything. So if we run models for maybe 6 or 7 times, can we do it in 4 times? Can we do it in 5 times? So we measure that, we reduce the process. In some cases, do we need 90% accuracy? Would we be okay with 88% accuracy if it's going to require 60% less energy? So we're measuring every single thing of that. And now we're extending it to water usage as well. We're trying to sort of cut usage costs. We might run the algorithms at night rather than day. So more and more, we're trying to incorporate these strategies because we owe it to the future generations as well. Next slide, please. And like I said, one of the things I'm very, very firmly believe in is there's a huge need for a human domain expert like all of you, because there's certain things that I've learned from my teachers, including B.S. Chaube and everything. They used to look at the patient and build the answer before actually examining the patient and so on and so forth. The domain expert has a lot of expansion knowledge. There's instinctive things, there's intuition as well, and there's some issues of ethical constraints of how they can manage the patient. An AI system is never going to learn all this because it's going to be dependent on essentially what its training mechanism is. So what about combining the two? Can the two working together in a feedback loop? Because the expert is going to pick up things which the AI system may not. It'll bring in guardrails, it'll stop sort of things from going haywire, but the AI system is going to cover for the fatigue that the patient has, the doctor has, for example. In a busy clinic, 70 to 80 patients are seen in the whole day. There's no way any physician is going to sort of have the same sort of accuracy all throughout. He or she is going to miss things. So can we make this better by incorporating some? The second part is when we use multiple algorithms, how do we know that things are not being made up? You all heard about hallucinations and so on and so forth. Next slide, please. So we make everything explainable. So if someone wants to see why is this answer coming out the way it is, we explain the reason. We try and explain the reason as to why this is the way it is. And this is how we're building our decision support systems as well for human mass. And eventually we hope to build it for polycystic disease as well. Next slide, please. Next slide. So this is something that has been, for the last 5 years I've been working on. Next slide please, I'll show you one thing that, as an example of how we take this ahead to what sort of clinically relevant domains are there. A patient with prostate cancer metastases everywhere. Once we know that it's spread everywhere, okay, we define it as metastatic disease, but treatment-wise, an oncologist may partition into organ metastatic, localized. Is the patient symptomatic? Is the patient symptomatic because of the metastasis to a weight-bearing vertebra? Is it in the appendicular skeleton? Is it in the axial skeleton? All of these things make a difference. And this is how the patient's treatment changes. So what we did was trying to incorporate all this domain knowledge and put it back into the model, and we gave the physician, the radiation oncologist, the surgeon, everyone this information, because everyone has different questions. And so for prostate cancer, we built this with sort of putting in every possible feature, and then we're not telling anyone what to do, but rather this is information. If you can ask the questions you want to do for this, maybe we can improve the way we report radiology. Because otherwise, we're just going to see many osseous metastatic lesions throughout the spine. That is of no use, because there might be one lesion which is more important, one lesion that will need treatment, say that is the one which is painful. If it's only selectively in the pelvic bones, maybe that can be treated by radiation and effectively can downstage the disease. So all of these important questions are important for us all to work together, especially me, because I'm sort of out of the clinical realm, but this is what we're trying to do. Thank you. If there are any questions, happy to answer them now or later.
Because I've not been exposed to this earlier. What I understand that you put all the clinical radiological data, all the questions as much as possible to the, and once you put this data, then it starts analyzing, and they analyze radiological image based on those data that you have provided. Is it?
It's not only radiology, everything about the patient as well. Age, the gender, and we looked for renal masses, we looked at everything. Has the patient a smoker? Is the patient got Hispanic parents? Because they are resistant to certain forms of treatment. Is the patient got Asian parents? What is the heritage? How long has they been? So we put in all that information in. And so that is what we're trying to do. Because this is information that's available. If we don't use that, that will be foolhardy of course. Because this provides prognostic information. How is the patient going to react? How is the patient going to be 5 years from now, and so on. So the good thing is none of the information you have to spend extra money, no extra tests. All of this is available.
Is it answer?
Absolutely. And that is why the interfaces we are building. The AI is never going to give the answer, at least the way we want to do it. It'll only provide suggestions. It'll only present the information to a urologist, to a gynecologist, to a nephrologist, to anyone else in the format that they wish to. It is never going to me, the ideal system is just going to provide maybe a second look. If I had AI systems in my workplace, I would still see everything myself clinically. Then I will activate an AI system, look at it, and then see. Because knowing this, an AI system almost always is being trained to pick up anything that is even possible, so it's going to pick up hundreds of things which are incorrect. You don't want that. You don't want that as the first thing. You want that as the second thing. So no one has the time to do this. And in clinical practice, we've seen that if you incorporate AI, it actually lengthens your work. It doesn't reduce your work. It actually makes it more and more longer. So you have to be careful. Look at all of them. There will be specific imaging signatures that are available in the image, which are highly likely to be. So without doing a test, there are certain things like, for example, okay, I'm slightly taller than the average person from Nagpur maybe, but that is maybe my family or scholar. But things like that. My complexion is the way it is because my parents and my father's side. So this is information that's not available from me, but is available from background information. We put in all that information into it. So that is what we've done for mutations, for bladder cancer, for example, for other tumors as well. We found imaging signatures which are very, very specific for certain. Can we do it for everything? No. But we can find a very high possibility of mutations, which are relevant. So PKD1 versus PKD2, I think we can.
Basically, generating data from whatever studies have been done, whatever new information we are putting into the system, and then creating a new data out of all the things available and giving suggestions.
So if you look at it in two different ways, right? Would you believe Microsoft or Google doing this, or would you prefer to have us doing this? So I think the answer is we need to be involved in this process. And this is where the problem is, because Google develops this model, Meta, Microsoft, all of them do their own foundation models. No, we've trained on this. If you imagine what is going to happen 10 years from now, medical students are not going to be looking at it. No one's going to ask for take part, no one does that even now. But it's like driving a car. Like my daughter hasn't learned driving a car the way we did because everything is fully automatic. So she's never able to. At some point in the future, things are going to fail. You need to be able to drive. She can't do it. So it's things like that. You can't have these processes go on without any safeguards. Also, there are specific questions which you, as a nephrologist, know are going to be important. For example, is there one cyst amongst the others that is going to be big, that's going to be symptomatic, that's going to cause pain? Is it some cyst that effectively you can aspirate and reduce the symptoms? This AI model is not going to tell you, but perhaps you can. Changes in how the cyst appears. So there are things which medical knowledge and the experience that you all that cannot be replicated. So that's some of the things that we think about.
How far are we from you people predicting the histology of small renal masses?
So we are pretty good. The last patent that was just approved, we went from benign versus malignant with close to 84% accuracy across 1,500 patients. We're now predicting indolent versus aggressive. We gave it sort of ISO grade 3 and 4 versus 1 and 2, 4 centimeters and above, 3 centimeters with the chromophore, sarcomatoid features, all that. So we're able to differentiate that with 82% accuracy just from the clinical CT state, nothing extra. Is that useful? It's useful for patients that who might then go on to active surveillance. Is it going to replace a biopsy? No, because if the patient wants it or you want it for whatever reason, you still go out and biopsy. But a biopsy there costs $5,000 to $7,000. 2 days of the patient's sort of life is in the hospital, whatever, taking time off. So all this start impacting. And if it doesn't make a difference, if this and 10% of all biopsies fail because either the target is not hit or you don't have enough tissue. So literally the difference between us doing it like this and a true biopsy is 6 to 7%. So this is how you. So rather than that, what we've now done is 84% accuracy, but even amongst the patients, this is where we're actually very, very certain that this is going to be high accuracy. And there's a group in the middle where we're not sure, maybe 66. So we're actually putting that likelihood chances up, so then you take a decision. We're not telling anyone what to do, but we're giving you the information, and you're the best judge. You and the patient together will make a decision. So it's things like this. What is the best way of doing this? We don't know. It was, to me, every disease is different. We can't have one model doing everything, and that is why I don't like the way some of these big tech companies do it, and hopefully this is the way.
Do we have?
Yeah, absolutely. So simple things like the cyst intensity, and that is one of the things I didn't put into this, but the way the cyst changes in the intensity on MR or CT, or like most of the patients get MR for these specific reasons because it is a biomarker. But we can do it based on the combination of that even if there's no urine pus cells or anything else, but simple slight elevations together can actually improve the accuracy of the tumor. So it improves the accuracy of this question. And above all, it's your own intuition, right? You know that the patient has an infection. You know intuitively without looking at it. So that has value as well. So imagine that this information is available to you as an extra second pair of eyes. And then you take the call. This is what I think this system should be. No one should be telling you what to do. You are the best judge along with the patient. You can decide.
Will it be applicable to all cystic diseases of the kidney or only ADP?
ADPKD is a more unique process, so we're doing it like this without knowing how it, like for example, medullary cystic disease, completely different disease spectrum. Unlikely to be using the same model, but if we have enough cases, we'll test it. But from every piece of information we have, we're trying to gain more and more. Like we have now been predicted, and we automate nephrology scores for surgery for kidney tumors. We predict renal function change. It's 3 months from now, so that's being published across multiple data sets now. So all these things, because this is useful information, right? Are you putting potentially a patient who has borderline renal function, GFR is down in 50s, do surgery, and you're putting the patient into a risk of dialysis. And you have to measure the cost, you have to sort of counsel the patient and so on. So all of these questions are unique, and
In neoclassification, there are variety of cystic disease of the
Mhm.
kidney.
Yeah. absolutely. I mean, the knowledge that we gain from this is going to be immense. Can we apply it directly for everything? No. But we definitely can.
Moving slightly away from ADPKD, we are still using the Bosniak classification for cystic renal tumors. So is there anything new on those lines?
No.
Something more predictive or AI?
Bosniak is still the gold standard. Why? Because it's clinically relevant. It simply determines what is the likelihood of this being malignant or not. As simple as that. Because that is the reason why the system is there. It's got nothing to do with how this appears. So you know that the chances of one thing that has changed over the last few years, let's say Bosniak 3 and 4, the likelihood of cancer that the patients have is up in the 60s and up in the 80s. What it doesn't tell you is that most of these cystic tumors are extremely indolent. So that is the one change that is not accepted in hospitals.
So there will be some extra criteria or marker for the indolent and aggressive?
No, there is nothing as yet, because these morphological markers are not yet proven. So this is where we need something like this, where you have more information that can put it in line. Remember, think of these systems as an intelligent friend rather than someone who's telling you what to do. And so you can ask questions, and this is where the importance is.
Beat trial has started or is enrolling the
Beat Pickety started.
They started.
It has started there, 3 centers, only 120 patients out of it, 60 will be placebo. 4 years is double blinded, so we don't know who's getting what, but based on this, I think we can start predicting who's getting what. So, but for 4 years, it'll be locked. Even we wouldn't know who's getting what.
ADPKD is very, very slowly progressing. Even the height adjusted kidney volumes, it is even yet to stand the test of time. So, what does this AI model? I mean, what are the points where it scores over the height adjusted?
No, so a couple of things. The height adjusted kidney volume. It is not going to predict the actual volume of the kidney in the future. What's doing is predicting what is the likelihood of this patient going into dialysis at what stage. It's going to be 3 years, 5 years, and so on. So that is what is it. So it's a baseline measurement used to predict renal function change in the future. For that, it's better than anything else we have. At this moment, there's nothing else that can do the job. Can we do something else to improve that? Maybe yes. Like this is where building those conditional flow models, right? Because we can actually put in those questions. I'm going to change the diuretic 1 year from now, 6 months from now. What difference does it make? So we can try and answer that.
Apart from ADPKD for the say native kidneys or transplant kidneys, can we use MR or some kind of imaging modality to predict the fibrosis or amount of fibrosis in the kidneys? Because every time otherwise we are supposed to do a biopsy and see how the fibrosis.
So we are doing that, but the thing is, the proof of the test is like how many things you prove it on, right? So for example, we have this huge database, and that's why we can say with confidence, we can give all those answers, but it's a tried and tested process. The things for renal fibrosis, is it ATN, is it something else that's happening? There is information, I mean, not just from what we do imaging wise, histotripsy and so on and so forth can give you these answers. We haven't done that because there's only so much time in the day, so I'm focusing on things that interest me. But the other people do. Hopefully we should be able to get these answers, including Doppler ultrasound. You can see the change in the pressures, the change in the vascular profiles, change in the resistivity index. All of those together is pretty good at giving the answers.
So selecting diseased kidneys for whether they are fit for transplant or whether they should be discarded based on taking marginal donors. Is there going to be some imaging modality which is going to help us out in that?
In theory, yes, but all these issues, right? Unless you test out, you won't be able to see it. I think the problem is the whole system, right? For example, you have a specific question in which you want to select right versus left versus actually something that's going to use. You're going to use as a transplant. This question often doesn't get relayed to the radiologist, and he or she is not going to read the question. So they're just reading out in the normal scheme thing, no obstruction, no stone, whatever. This is lost because we have a legacy system of how radiology works. It's a basic report which doesn't answer the question. And unless that changes, and hopefully this system is because hopefully it will become a bit more intelligent, evolved, and we can start addressing these issues.
A lot of work AI is doing for knowing the fibrosis and the pathology which is going on the kidney without the need of doing a kidney map.
Yeah, absolutely. I think the more important role is it's reducing the number of patients who need a biopsy. Right? For example, if you have 100 patients, 40 or 50 patients, I can tell you, hey, we don't need a biopsy, either yes or no, but it will reduce the patients who need a biopsy to 40 or 50. And so that itself is a big gain because that helps a lot, reducing costs, reducing burden, and you also can repeat it in multiple ways. And this is now, especially in the liver, hepatic steatosis, it is actually now FDA approved, mandated, and people are getting treatments without a liver biopsy and checking the level of fibrosis. And there's no reason why this can't be applied to the kidneys. Because people are getting treatment and monitoring the effects just based on these MR assessments without biopsies.
And you have not expected a particular answer, but AI provided you with that. That kind of scenario, did you get such kind of surprises?
Absolutely. That is why this is called loop, right? You always have a human guide. Look at it cynically. The healthcare legal system, whether it's in the US or it's in Europe or here, still needs a human doctor to see. So that is not going to change. Even if you put in an AI, the AI company is not going to take the responsibility. The fault is still going to be there. So, until such time, I mean, you are still responsible for any decision. The companies are not going to take that responsibility. Therefore, you have to be involved in the process. That's why it has to be an open, transparent process. You've got to know why this is happening the way it is. And it's part of, like, I think this is an essential part of what training, I think, should be for medicine as well. The good thing is there's a lot of, the students I work with, there's a lot of medical engineering students who cross over, they work together, but there are also lots of engineering students and now choosing medicine. A lot of the medical students can actually code way, way better. I can't code still, but they'll do a fantastic job of things like this. So the next generation of medical students are going to be far better than this. They might use it in a much better way. But the frightening part is they might understand, they might not remember the lessons while they got to this place. This whole bank of knowledge that you all have, collectively, this individually. This patient is not going to benefit from this treatment. Nothing written in any book, nothing that any algorithm is doing. But you know certain reasons. Some patients you know are not going to take treatment for. Some patients just have bad profile. So this is where your intuition and exponential knowledge comes from. So that cannot be replaced. Job profile. Most of our residents get jobs second year, third year. They have jobs secured at as high a salary than I get. There are plenty of jobs available because the same thing. Every report still needs someone to sign off. What everyone is being asked to do is work harder. They get a lot more, but there is a lot of uncertainty, like what is going to happen in the future. But what is happening is things that no one wants to do. Things like chest X-rays. What is important if like our ICU, there are about 120 chest X-rays done overnight. Commonest reasons for the chest X-ray is the entity in the wrong place, and the endotracheal in the wrong place. IG line is one thing. You don't need to wait until the morning when the radiologist sees it. 3 specifications, you can train 3 models and run them. So you can have those being flagged, shown back to you before a radiologist sees it. So that to me is clinically relevant AI because all you're looking for is the entity in one place. You don't need to wait for 8 hours for a radiologist to see it. Someone else can see it. Everyone would love something like this. So a couple of hospitals who have done that, and we are trying to do this. So there are agent-specific tasks that can be built for not just the overriding. You're still going to need someone to look at it. Is there a completely unrelated pneumonia or pulmonary embolism that showing up on X-ray? So you'll still need a radiologist 6 hours from now to look at it. But important, immediately relevant questions. Is there a pneumothorax? Is there an entity going on wrong? So you have an AI-generated report, AI triaging of patients, and you have the final report. So you can do all of these things. None of them are exclusionary. Everyone has its place, but it's need-based.
Very excellent talk, and you answered so many questions. And of course, there are going to be many more questions. Do you have around the PD stand here and there questions to ask to sir? You have visitations you may have to.
No silly questions, only silly answers. Answers not the silly answers.
Sir, you must let them know that he is a contributor to Brenner's Nephrology. That as a Bible. Vinay, something on that please.
Yeah, for the last 3 editions, including the latest 12th edition that just came out, I'm the lead author for the Radiology Society. So for the last 12 years, that's what I've been doing. Similarly, for renal masses, I lead the imaging chapter for renal masses, SIU guidelines. I contribute to the AUA guidelines and so on and so forth. So, I work more with Vasu's colleagues in neurology, more with nephrology than people in my own department. So that's the way things are going. So.
Okay, man. We are also proud that you are making such
Thank you. That's honors mine. Really. Thank you.
Thank you, sir. Thank you very much. Yes,
We have an official photograph.
thank you, sir. This faculty will be coming, Dr. Vivek Kude, Dr. Firoz Aziz sir, and Dr. Pratik Das sir. And we'll have a panel discussion on that. The theme is the expansion of a living donor pool. We'll have a ABU incompatible transplant, HAD incompatible transplant, and swab transplantations. So I request you all to attend the Sunday morning. Thank you.
I request you to honor.
Thank you very much, sir.
Thank you. Thank you.
Tell you a lot of good things, but I can certainly tell you what mistakes not to make. I spent a lot of time going to various places because I wanted to do certain things. So, and also knows this. So I started doing medicine. I spent 2 years doing MD medicine, but it did not. This was not what I thought it would be. So then switched to radiology. I went to the UK, had my UK graduation, had my UK license, then wanted to work with someone in Vancouver, so went there, fellowship to there, came back to the UK, have a European license, and then finally in the US because I wanted to do things like this and the other things I'm doing as well. Developing a new goal because essentially just keep your mind curious, and that's what I still do. Ask a lot of questions. And all of these people, they will always keep on pestering you. And that's what I think I want to do. When we were medical students, I know I was very reticent in asking questions, right? You're almost afraid. Don't be afraid. Ask any questions. The answers are going to be, go and read it up, or I don't know. And there may be something wrong with it. You have to ask questions. Because otherwise you have companies going to take over some of the things you do. You shouldn't. So you have to be part of that process. And just keep on asking questions. I mean, the wealth of knowledge that all of these people have is huge, absolutely huge. And that you'll never get from any book. We all learn from, at least I learn from all the mistakes I make, all the things that I don't address, and you'll always think that ये क्यों नहीं बताया मैंने?
Arts and this thing. I think he is one of the polymaths that we should try to learn and catch those things, that don't stick to your specialty but take ideas from whatever you can. So lot of engineering students, it was difficult for me to comprehend what a doctor is teaching to engineering students, but yes, he'll tell you that so many of his students are engineers, as 12th class he said.
Many of the MDs thought of, but AI picks it up.
So, but it might pick it up, but it will also make it up, right? So there are two things. One is philosophically, a physician thinks of, and this is, I might be sort of taking sort of literary